You're welcome to my channel. Today I'll be talking about cerebral palsy. By way of definition, cerebral palsy is a group of disorders that can affect a child's ability to maintain posture and prevent the child from moving around easily like the rest kids in the population. Cerebral palsy is mostly secondary to abnormal development of the brain or damage to the developing brain. The common cause of motor disorder in children is cerebral palsy. Going down to break down this definition further, in cerebral palsy, there will be weakness. That is the meaning of palsy. The weakness will be affecting the muscles and also affecting posture. So there will be motor disability. And of course, seen in children. Cerebral palsy is mostly diagnosed within the first and second year of life. But that's not the end. Mild cases could be diagnosed at older ages, like 5 years or even more. When cerebral palsy is diagnosed, though within the first and second year of life or 5 years, is going to remain till adulthood once it is diagnosed. We have to check the developmental milestones very closely and lay emphasis on the motor. There are two main broad types of cerebral palsy. It is either congenital cerebral palsy, meaning surrounding pregnancy and birth. So it's either before or during birth. That is congenital cerebral palsy. The acquired cerebral palsy is possible after birth and even after neonatal period. And that will occur as a result of meningitis or severe head injury. Now, there's a controversy on whether or not cerebral palsy is hereditary, meaning, is it having genetic link in one way or the other? Well, it is still equivocal to say no, that it is or it is not at this point in time. A big center in Toronto in Canada conducted a research on that, but as of today, there is no journal or complete research establishing that genetics is fully involved in cerebral palsy. But I don't have the authority to rule that out at this point in time. So we'll wait for further research and conclusion that will be acceptable to neurologists, to pediatricians, and then worldwide. So it is still equivocal at this moment, because if you go through some literature review, it is categorically written that it is not hereditary. In fact, the example was given of a man who had cerebral palsy and went on in life to give birth to children without cerebral palsy. But with the research done in Toronto, now a small percentage, about 5 to 10%, had some level of link to genetics, but that is not yet fully established at this time. Epidemiologically, about 2 in 1,000 live births will come down with cerebral palsy. The prevalency is greater in preterm babies. The higher the gestational age, the lower the chances of having cerebral palsy. So, cerebral palsy is inversely proportional to the gestational age. So, when the woman could carry the pregnancy to term, the chances of having cerebral palsy will drop. The higher the birth weight, the lower the cerebral palsy, just as gestational age. Higher gestational age, higher birth weight, lower cerebral palsy chances. It is more in boys than girls. Well, I don't know why, but that is what we found. More in blacks than whites. Still on epidemiology, 50% may be able to walk independently, 10% will need walking aids, 40% will have seizure disorder or epilepsy, 10% will have autism spectrum disorder. Now there's a shift, and that is going to be a good news by the time I'll be done on this page. From 1960s to 1980s, there was an increase in the rate of cerebral palsy. Whether? Probably because of an improved medical services, leading to more preterm babies, making it at neonatal intensive care unit. In other words, before then, most premature babies would die. But within 1960 and 1980, more preterm babies will pass through neonatal intensive care unit, make it to full life, discharge and go home. But they will come down, most of them will come down with cerebral palsy. They are not dead like before then, but disability in them, now quote and unquote cerebral palsy, will become obvious. Between 1980s and 1990s, more improvement has led to more matured infants. Remember, I've said preterm birth is a very strong factor leading to cerebral palsy. Now, more matured infants are given birth to, meaning there will be less cerebral palsy, even when they have low birth weight. The proportion is, however, stable amongst term infants. Now, what are the possible causes and risk factors when it comes to cerebral palsy? It is all about brain damage before, during birth, or within 5 years of birth. It is worse or more likely in vitro conception, meaning people with infertility that will then have the conception, done, reproductive therapy in short, anyways, in the lab, then they may stand the chances of having more cerebral palsy. Cancerous can end up with cerebral palsy. If you check my channel, there's a separate and full presentation on cancerous right here. Please check that out. That is a high level of bilirubin damaging the brain. Birth or delivery complications will lead to cerebral palsy. Bleeding in the brain, my basic cause. Still on causes or risk factors, it is mostly idiopathic. In medicine, we have somewhere to hide. When we don't know the cause, we call it idiopathic. But it is multifactorial often. Bed asphyxia, that lack of oxygen to the fetal brain, is a culprit. Maternal hypothyroidism, congenital malformations, perinatal stroke, or severe placental pathology all could be responsible for cerebral palsy. Now, prematurity. Cerebral palsy is fewer if the woman is lucky enough to carry the pregnancy up to 36 weeks gestational age. But the luck will drop in gestational age between 28 and 32, and worse when it is less than 28 weeks. When it comes to low birth weight, we'll be looking at anything less than 2.5 kg. Once it is 2.5 kg and above, the chances will drop. And it will be worse in anyone who will give birth to babies with less than 1.5 kg and below. the chances of cerebral palsy will increase with lower birth weight. Still on causes and risk factors, chorioamnionitis in a pregnant woman, yes. Touch, that is toxoplasmosis, rubella, cytomegalovirus, and herpes in pregnancy will be a culprit. Malaria in malaria endemic regions of the world and other infections in pregnancy could be responsible for cerebral palsy, just as preeclampsia could be. Still on possible causes and risk factors, placenta abruption or bleeding in pregnancy generally, multiple pregnancy, heavy alcohol in pregnancy. So it's not only fetal alcohol spectrum disorder that will be a problem. No, that might be a recipe for cerebral palsy as well. Maternal smoking, so no boozing, no smoking. And of course, small for gestational age will be another possible risk factor. Still on risk factors or causes, low Apgar score at birth, neonatal respiratory distress syndrome, neonatal seizures, any condition requiring antibiotics during or after birth, that is, conditions suggestive of infection, will likely be the cause of cerebral palsy. Now, how do we make diagnosis? Full history, and the history will start from the mother, the history surrounding the pregnancy, from the beginning to the end. And of course, physical examination, full neuro with all the primitive reflexes must be examined. We have to focus on developmental milestone as early as possible based on the time of presentation, but we will trace it back till pregnancy and delivery. We have to rule out other similar neuro problems. Don't worry, you have the list of differential diagnoses right here. Is it progressive? If the answer is yes, then it is not cerebral palsy. Cerebral palsy is not progressive. Please be precise on which type of cerebral palsy. Don't worry, in a bit we'll go through the different types of cerebral palsy. Now, we're not done yet with the diagnosis. We'll head to the lab. We can have enzyme link immunosorbent assay or polymerase chain reaction, Western blot, or anything like that, just to rule out all the viral infections and other agents that could be suspected to be the culprit here. We can have blood culture done, thrombophilias testing, clotting assays, and immunoassays. We can have complete blood count, electrolyte, renal function test, liver function test, and thyroid function test done. Radiological investigation is welcome. We're talking about problem with the brain, right? So it is appropriate to have EEG done, electroencephalogram. Then we can have CT of the head, looking at the brain entirely. Magnetic resonance imaging will be helpful. Now, the clinical features. If you've paid close attention to this very presentation while talking about the diagnosis, I've laid emphasis on developmental milestone. The same when it comes to the clinical features. So we check for developmental delay, muscle stiffness, and muscle tone that could be decreased or increased under certain situations, and also motor function disorder. The primitive and involuntary reflexes should be checked. And then we'll say that some will have learning or intellectual disability. Some will come down with seizures or even epilepsy. Some will have swallowing difficulty or speech disorder. all these features will be what will be coming across, either one in particular case or more than one of these characteristics when it comes to the different types of cerebral palsy. In other words, some of this cerebral palsy that we'll go into in a bit will have some of these features. Now, specific type of cerebral palsy, spastic subtype. This is the most common type of cerebral palsy. It's going to occur in about 80% of all cerebral palsy cases. Here, there will be intellectual disability, but it may not be present in some. Some may have serious incapacitation like swallowing difficulty, respiratory failure, or even seizures. Sensory deficit may be present. Talipes equinovarus and cacanovagus may be present here. Still under spastic subtype, infants and children within birth and 5 years will have hypotonia, spasm of the ankle and feet, delayed developmental milestone, particularly motor and psychomotor. You have crawling difficulty, abnormal posturing at age 2, and leg extension while sitting. You can just figure that out. The child is sitting and the leg is not being folded, rather is extended. So you can be suspecting. Okay, still on spastic subtype, if it is in a child greater than 5 years, then we might be faced with upper motor neuron lesions. And the features will include hyperreflexia, hypertonia, ankle clonus, with or without muscle contractions. Now, spastic subtype could be broken down further to either be spastic hemiplegic. In that case, it will form about 40% of the spastic cerebral palsy. Hemiplegic, meaning it's going to affect one side of the body. That half side will involve the arms being affected more than the lower limbs. So the legs will suffer less, the arms will suffer the most in spastic hemiplegic cerebral palsy. There will be weakness, otherwise known as paralysis, affecting that side of the body. So it's only one side that will be affected. The other side will be normal. In spastic diplegic cerebral palsy, that will affect about 10 to 20%. Here, there will be muscle stiffness. But unlike hemiplegic, that the arms will be affected more than the legs, here legs will be more affected than the arms. In other words, lower limbs will be more affected than the upper limb. There will be decreased muscle bulk in lower limbs. Of course, disuse atrophy, right? Then there will be more difficulty walking. Of course, because the lower limbs are more affected. That's obvious. And one classical presentation is that they will have scissoring when they're moving. Now, on spastic subtype, the last here is spastic quadriplegic. This will affect about 40%. All limbs are affected. Some may have upper limb affected more than the lower limbs. And this is the most severe form of spastic subtype. Of course, needless to say, right? All limbs are affected. Even trunk and face are also affected. They can't walk. Then what will happen? They'll be mostly confined to the wheelchair. This is associated with other problems like seizures, visual problems, hearing difficulty, and speech disorders. This is horrible. It's the worst, of cerebral palsy spastic subtype. Now, moving to the second type of cerebral palsy, which is dyskinetic cerebral palsy. This is mostly from perinatal asphyxia leading to brainstem damage. It's going to be occurring in term infants, and here we'll be dealing with hypotonia at rest. There'll be hypotonia on exertion or when there's an action. They will have dysarthria, and the primitive reflexes will be intact. In dyskinetic cerebral palsy, there may be grimacing, drooling, tongue and face will be affected. Of course, we've seen drooling and grimacing, right? They can't talk, or they will have aphasia. They will have swallowing difficulty. And there's something that will give you a clue here. They will be persistently turning heads to one side. They will have delayed psychomotor development. Still on dyskinetic cerebral palsy, they will have chorea. Chorea here is rapid and unpredictable irregular contractions of individual muscles or small group of muscles like the face, the fingers, the upper limb, the bulb, the toes. Also, they can have athetosis. Athetosis will be slow, smooth rhythm movement that will involve these two muscles. The movement here will be triggered by changes in emotion and posture. So, when they are subjected to stress, or they are excited, or they have fever, then athetosis will show up. Still on dyskinetic cerebral palsy, there is an entity known as Dystonic. Here, there will be repetitive and pattern twisting or sustained movements of the trunk and the limbs. It may be slow, but sometimes could be rapid. These will be characterized by 1. Hypertonia of the flexors and extensors during emotional high or attempted movement. Okay, then also could be characterized by normal tendon reflexes, but clonus will be absent. Plantar response will not be present. Now, the third cerebral palsy type is atasic, mostly idiopathic. When we don't know the cause, we call it idiopathic, right? Some stated that it could be genetically linked. Well, we need more to prove that. It is rarely associated with congenital hypoplasia of the cerebellum or Joubert syndrome. It occurs in term infants, and the presentation will include slow, jerky, and explosive speech. Delay motor and language skills are present here. Still on atasic cerebral palsy, here the problem will be with balance and coordination. They'll be unsteady when they walk. They'll have difficulty writing, difficulty grasping stuff, difficulty moving very quickly, and there will be ataxia that will improve with time. This is pretty good, right? Although we don't want anyone to have all of these issues, but atasic is preferred, right? Because the older they become, the situation will be getting better. They will be mixed. In this case, some may have more than one type of cerebral palsy subtypes at the same time. For example, they could have spastic with dyskinetic. Then they have spastic dyskinetic cerebral palsy. Most pediatric textbooks and neuro textbooks or literature review will tell us about 4 types of cerebral palsy. Now, this fifth one that I've put up here is known as Atoning cerebral palsy, but follow me why those pediatricians and neurologists will be right. Okay, here it is known as hypotonic cerebral palsy. It can be atonic or hypotonic in infancy. Now, the reason why they might be right and limited to 4 is this. After infancy, this atonic cerebral palsy or hypotonic cerebral palsy will change. It will change to either spastic or dyskinetic, or commonly to athetosis cerebral palsy. So, to those who have not labeled this as a separate type of cerebral palsy, they are right, because you just watch the child with time, the child will come down fully as spastic or dyskinetic or athasic. So that's why many textbooks or literature review will not pick this. But in infancy, you can give that diagnosis as hypotonic or atonic cerebral palsy, telling the parents it will change as the kids will grow older. Now, treatment. There is no cure. We should be honest with ourselves. But all interventions should be multidisciplinary in nature, multidisciplinary approach here. We're going to involve the family from the onset and in everything that we do as per that child. Medications could be helpful, but it's not going to cure. I'll give you the list in a bit. Some will even undergo surgery, and we will go over the entire risk factors with the parents. Still on treatment, intervention should start from birth, but I'll even state here categorically that the treatment should not only start from birth, should start while the woman is pregnant, particularly immediately she misses her period. We will see the reason why concluding in a bit. In some countries, like in US, they have Individuals with Disability Education Act. That could be done to help these kids. The government will be involved. Then we'll help with learning new skills. Families should be supported, and the training should be given to them on how to support these skills. To those, because once cerebral palsy has occurred, there's no cure, so they live with it till adulthood. So occupational support should also be part of the treatment. Still on treatment is physiotherapy, speech therapy to those who have dysarthria, auditory therapy for those who have hearing difficulty, assistive devices, walking aids, and so on, and of course, transportation for them. Still on treatment, school children with cerebral palsy should have special attention. They should be provided with adaptive equipment and other stuff that I've mentioned above. Then special education services that will cover individualized education plan and individual family service plan. All these should be in place to help both the family, that is the parents, and the affected children. Okay. Treatment and medications. Remember I said earlier that we can't cure this, but you can relieve some of those symptoms using certain medications. Okay. I'm going to go through the list of some of the medications you can choose from, but that should be after due consultation with your pediatrician or pediatric neurologist, or clinical pharmacologist, or your pharmacist, please. Then you can choose from baclofen, carbamazepine, clozapine, gabapentin, clonazepam, diazepam, Benadryl, benztropine, trihexyphenidae, procyclidine, carbidopa, levodopa, and tizanidine. In conclusion, prevention, they say, is cheaper than cure. That is, if the situation is even curable at all. For example, cerebral palsy is not curable. So, the essence of my presentation is to reduce sufferings and decrease death as much as we can. Here, we can prevent cerebral palsy by taking certain measures. To all those good women, all women still within the childbearing age, once you miss your period, please see your doctor. Your doctor will help you make that determination as per the pregnancy, whether you want to keep it. Great. Then, the schedule for antenatal clinics will be given, and a lot of instructions will be given to you. In fact, check my channel for a self-representation on the first antenatal clinic right here, and correct diagnosis of pregnancy. So, you'll be advised not to smoke, you'll be advised not to take alcohol. So, no boozing, no smoking. You can now see that if you don't adhere to those instructions, alcohol intake in pregnancy will come up with a lot of problems, not only fetal alcohol spectrum disorder, but including cerebral palsy. And throughout the pregnancy, please kindly report any concern or concerns immediately. For example, fever or bleeding should be reported immediately to your doctor for appropriate intervention. With that, I've come to the end of this very presentation. As per cerebral palsy is a very difficult neurological problem for the affected children. And once it occurs, it's going to be like that until adulthood. So we can do our best to prevent what is preventable. Thanks for listening. Remember to share this presentation and remember to subscribe to my channel. I appreciate it.